Greetings everyone once again. Welcome to the 137th session of the online Optom learning series OOLS. And for today's session, we have with us Dr. Nataliya. She is a medical doctor practicing ophthalmology, and also she does contact lens fittings with an emphasis on specialty contact lenses for overnight corneal reshaping, which is orthokeratology. She also fits patients with corneal ectasia, post-refractive surgery, as well as treats them for their dry eye problems with contact lenses. And she practices in Ukraine in her private eye clinic. He has been practicing ophthalmology for the past 13 years and have an experience of fitting more than 5,000 patients with Orthoke, right? And with that all experience, he has been lecturing nationally as well as internationally. And the main purpose of her lectures lies across orthokeratology. And she's also a fellow of the European Academy of Orthokeratology and Myopia Control. She's also a former representative of the Euro-OK in Ukraine from the year 2014 to 2017. And as an independent tutor, she also provides educational courses as well as trainings, help people to troubleshoot their fittings and contact lens fittings, and also provides clinical supports in variety of subjects, specifically orthokeratology, visual optics, specialty contact lens fittings and myopia control. And with all that experience, she is joining us from Ukraine, and she is going to talk about very interesting topic. I think as optometrists, now orthokeratology is becoming very important part of our life when we are, managing myopia and also refractive management as well. And how should we, look in for going about managing this complication? What are the things we need to avoid, first of all, to get this complication? How should we have a safe orthokeratology practice? She's going to share all that experience with us. So welcome, Doc, onto our platform. And, let me just leave the screen time to you.
Thank you, Fakhrudin, for so warm welcome note. I am really very pleased and honored to talk to you tonight and to share my experience in orthokeratology with our audience. So today I'm going to discuss the most common complications and side effects related to corneal reshaping. And we have about 45-50 minutes, which is extremely less, much less than I would like to have to share all my knowledge with you. So I will try to, to squeeze all necessary points into this talk, so you can get some clues about what is going on under the lens, what is going on the cornea during Orthoke treatment, and what risk factors we have, and how to prevent complications. As one of my old teachers said, the only way to avoid complication is not to proceed, and I'm absolutely agree. So when you want to learn about new method, you have to be ready to face with some complication during your practice. It's impossible to avoid them, but we will learn how to do that. So let me proceed with my slides. Of course, nobody likes statistics, I know, but we have to go through it to have some ideas about how often complications in Orthoke, and especially serious complications, which can or may lead to the vision loss, permanent vision loss. We have to know how often it happens and what kind of complications we may potentially face with. So the best way to do that is to listen to scientists, listen to smart people who already did some great job and made a systematic review of all possible publications related to ortho-K and related to complication during ortho-K. So I show you some articles. I will show you some articles, and if you want, you can go through them more thoroughly. So you can get some details by your own research in the internet. I will just cover the main general principles and the main information we can get from publications. So this paper was published quite recently, few years ago in May 2017. And it actually includes the result of 172 papers. And after, let's say, deep research and after removing duplicated and some irrelevant reports about complications in ortho-K, authors included 29 articles. And actually, all those 29 articles involved 173 eyes, which is quite low number, I believe, when we think about how many patients wear ortho-K lenses worldwide. Okay, so what we know from this systematic review, that gender is one of predisposing factors, first of all, and then female, the rate of incidence of infectious keratitis, for example, is nearly twice higher among females than males. So you should keep this in mind. What else we should know? That main infection keratitis, which is the most dangerous complication, are caused by Pseudomonas aeruginosa and Acanthamoeba. And despite early intervention and treatment, the majority of this kind of infections resulted in the formation of corneal scars. And about 10% of those kids needed surgical treatment. Saying surgical treatment, I mean, typically it's a penetrating keratoplasty. So it sounds pretty dangerous, right, for us. If even one kid, after leaving your practice, will get for years, you can practice for years ortho-K, and you can fit other types of contact lenses. But I believe even one kid who will end up with a penetrating keratoplasty, will damage your own reputation as professional, and will damage your, let's say, believing in this method. So we're gonna discuss how to prevent this very serious complications. How often can we meet with infectious complications, which are number one which is, let's say, number one problem and in safety concern raised about this method, because it can cause infectious keratitis, right? So we need to know that we have only one very good publication paper by Mark Bullimore about the risk of microbial keratitis with overnight corneal reshaping lenses. And what we see is that the incidence rate among adults is 7.7 for 2,000 lens wear years, and even like twice greater and among children. So children have the incidence rate is about 14 cases per 10,000 patients year or lens years. So it's pretty low again, but it's so serious complications, so we should keep it in mind, and we have to do all necessary steps during our fit and follow-up care to prevent these serious problems. Okay, so what other reports we have? What other reports we can find? What kind of complications other authors found during their practice? So the latest published paper from Russia describes 5 cases of keratitis related or associated with ortho-K wearing, and among those 5 orthokeratology cases, 2 were positive for Staphylococcus and Enterococcus, and all cases were monocular. And actually, they all were managed very well and treated without any loss of vision. And the patient were discharged from the emergency department with 20/20 vision, which is pretty rare for keratitis and ortho-K. Another data from China, which actually involved about 4,000 eyes, 3,800 eyes, sorry, in total. And lenses were fitted in 8 different cities in China from 2014 to 2015. So they took 1 year and analyzed what kind of complications they had in their clinic. And as you can see from the this table, so fluctuation of visual acuity, corneal staining, pigmented arc, corneal indentation, dimple wheeling, I will explain you later what is this, was among the most common complication, they didn't reported any serious infection complication like keratitis. So like 0 keratitis rate for 3,800 eyes. And you also can notice that pretty common stuff is corneal staining during ortho-K. We just will keep that in mind till the moment I will tell you more about possible side effects during ortho-K. So before we go through the list of all complications and possible undesirable side effects, let me briefly remind you what we are actually dealing with. And I want to remind you that we use a rigid or RGP lens, yes, so it's rigid gas permeable lens, and we use it for ortho-K, not for daytime wearing. We use it only for night time. So modern orthokeratology doesn't involve any daytime wearing. Actually, it's not rare. It doesn't exist. So all lenses, when you say ortho-K lens, you should remember that it is worn during nighttime only. So unlike other types of lenses, take a look to my slide, please. So other lenses like conventional RGP or scleros, they don't change corneal shape at all. So they don't alter the shape. They normally just want to be, make a parallel fit on the periphery or in the center, but they never change the corneal shape. And what is unique about ortho-K? It does change corneal shape. And we take only, for treatment, we take only corneas, regular corneas, without irregularity, without irregular pathological, let's say, astigmatism. So we use ortho-K for regular corneas only. Some designs Yes, they exist for irregular or post-op corneas. However, it's very rare, and most of the time, like 99.9% of your time, you're gonna fit ortho-K lenses for myopes, which is young, healthy, with a regular corneas. Some of your patients could, benefit from ortho-K having a hyperopia, but again, majority of your cases will be with young myopes. So what else we should remember about ortho-K lenses? That materials, because we use the lenses during the night time, that materials should be very highly gas permeable. So to prevent the corneal edema, to prevent the hypoxic stress of the cornea, we need to use lenses with a high DKT or high decay. For ortho lenses, the minimum decay parameter is about 100. And you also should know that materials with a decay T up to 20, or sorry, up to 200 is available on the market. For most of manufacturers use decay about 100 or higher for production of their lenses. So what else is different with ortho-K comparing to regular or conventional RGP lenses? They are both made of, let's say, hard material with a good oxygen transmissibility. No, my God, sorry. With a good properties to allow oxygen go through the lens, but the unique part of the ortho-K lens, it has posterior secondary curve, which we call reverse curve or RC. This one in this place, so in the mid periphery of the lens, so to that part of the lens, we incorporate the special steep reverse curve, which is always steeper than back optic zone radius, to actually start some changing of epithelium under the lens. So when we put the lens onto the eye, we induce changes in corneal profile by this special design of ortho-K lens. And how it happens? So the lens has central and mid-peripheral part, which play important role. Peripheral part, like here, is only for actually good alignment on the periphery, and it helps to centrate the ortho-K lens. But we're talking about this central and mid-peripheral part. As you can see, the central part is flatter than front surface of the cornea. So we want to apply something flatter than the front surface, which is treatment zone of the ortho-K lens. On the mid-periphery, we intentionally do the lens steeper, and by doing this, we actually induce different pressure forces in steep and flat parts of the lens, under the lens. So after applying the lens after some times, we expect that we will get epithelial thickness in myopes. If we're talking about myopes, so we will see thinner or flatter central cornea and steeper mid-peripheral cornea. So under the lens, there are forces which acting to the front surface, and we change the, let's say, architectonics and the shape of corneal epithelial cells, all those changes are, of course, reversible, which is a main benefit of Ortho-K, I believe. So you can reverse by stopping wearing the lenses. But by applying the lens, we definitely give these forces to make their changes with epithelium. So what kind of forces we have? So it's a lead force, surface tension, gravity, squeeze film force, because we squeeze tear film under the lens, and this whole space under the lens in the center of mid-periphery has different thickness of tear film, which actually lead to starting of pressure forces acting on the front surface of the lens. So after we take off the lens from the cornea, we see the changes in corneal shape. So our cornea become flatter in the center, as you can see on this slide, and become steeper in the mid-periphery. So you see now 3D corneal map of the front surface of cornea, myopic cornea treated with Ortho-K lens. So it's definitely flatter in the center, surrounded by a ring of steepening on the mid-periphery. So what is going on actually with our patients, and why we should be concerned about the potential risk when we do that? Because we take the healthy young cornea, normally kids' cornea, and we have some bad reviews of misinformed patients. They get the wrong information all around the internet. The treatment is really relatively new for us and for patients as well. So we take the healthy young cornea. I believe it's very high level of responsibility we take at that moment, and we temporarily change the front surface of the cornea by applying special forces under the lens. And another risk factor is the nighttime wearing of the lens. So we have to remember that we cannot, let's say, press the cornea enormously. We have some limits of the method. And it's all about Munnerlein's formula, which actually provide us with some information and the relationship between the treatment zone diameter and the prescription which we desire to change. And the higher the prescription we want to compensate, the smaller the treatment zone diameter will be. Because, why? Why we cannot, for example, change the epithelium without any limits? Because if we can decrease in the epithelial thickness in the center, right? So we cannot do it until the Bowman membrane. We can safely decrease the epithelial thickness only for 20 microns. If we go further, we have a very great risk of disruption of epithelium, which will lead to infection. It's an open gates for infection, and we definitely will get complications very soon. So you have to remember that the epithelium thickness in the center is about 50, 55, 60 microns, and we cannot press it to zero. We can do it only for about 20 microns. So it means that normally with Ortho-K, we can go absolutely safely with a treatment zone of 6 millimeters, which will lead to optic zone on the cornea about 4.5 millimeters. We can go safely up to -5, -6 diopters. If we want to correct higher prescription, like you see on this slide, -8, you see that mid-periphery is becoming steeper and we can see the treatment zone is getting more smaller. Okay, so it's getting smaller and smaller. So let's go to the next slide. And you probably wonder what happens under the lens, because when interest orthokeratology started to raise, many practitioners had concerns about what is going on with epithelium, with stroma, with endothelium. Do epithelial cells migrate somewhere to the periphery and then migrate back to the center in the morning after we remove the lens? Or what kind of stromal changes we have? Do we have any stromal changes, or we alter only the epithelium? So many questions raised. So I will go through all changes briefly so you can understand what is going on under the lens. It's crucial for later understanding of potential complications risk. If you don't understand what is going on under the lens, what is going on with cornea, it will be very difficult for you to, to get some logical, clinical logical connection in your head, in your brain, to understand potential findings, or to understand some findings actually you might meet during follow-up visit. So what is going on under the lens? Starting from first application and until 2 weeks and even 1 month, if we talk about myopic patients, so we see the flattening of their central part of the cornea and steepening, or let's say thickening of mid-periphery. It was done, the first publication about this was done by our colleague, and she does her paper on cats, animals' eyes, of course. Okay, so you can see the histomorphological cuts of the cornea after 14 days of treatment. And we definitely see that in the center, the epithelial cells has changed their shape. Yes, so it's become more flat and thinner. But in the mid-periphery, actually all epithelial cells become more elongated, let's say, thicker and elongated. And another Russian colleague found that after Orthokeratology treatment and during Orthokeratology lens wear, she found some displacement of lenses and found some displacement of changes in Bowman underlying membrane during Orthokeratology. So what else you can find? You can find the pigmented iron rings or some arcs, which corresponds to the mid-periphery, which correspond to this area of thickening the epithelium. And it's a normal result of chronic wear of Orthokeratology lenses. And incidence of these lesions actually associated with the duration of Orthokeratology treatment. So as longer you wear Orthokeratology, as much, let's say, incidence rate of this pigmented arc you can meet. So what is this? It's iron deposits in subepithelial layer, and it's absolutely clinically insignificant. So it's not a complication. It's what you can see on the cornea. So don't be, don't worry about that. And it's absolutely normal. And after discontinuation of Orthokeratology treatment, you will see in few months that this iron ring will completely disappear. So absolutely no harm for cornea in this case. What else we know? That again, cells in the center became flatter, and in the mid-periphery, cells became thicker and change their shape. There is no endothelial changes during orthocare at all. So orthocare doesn't alter the endothelial pump. Why we need to know that? Because if it does, we may, let's say, expect some corneal edema, right? So we can expect problems like edema from damaged endothelial pump. So there is absolutely no changes, and many publishers confirmed that there is no changes during orthocare treatment in endothelial layer of the cornea, as well as in stroma. So there is no stromal changes. The layer or part of the cornea which we only alter its epithelium cells, all layers of the epithelium, but there is no stromal or endothelial changes during orthocare. What else you should know? That by applying some pressure over the lens to the front surface, step by step, we changing the corneal subepithelial nerve plexus. And please take a look on the picture. So before, it's about morphology of this subepithelial nerve plexus in patients who never wore orthocare lenses, and this one after 9 years of orthocare. So if we apply this to a picture of cornea, we can see that we have some flattening again of this nerve plexus in the center and some thickening of nerve fibers in the mid-periphery. And that's why, if you look carefully to, during slit lamp examination into corneas of your patients, you can see something like a, let's say, thickened, more thick corneal nerve, nerve fibers in the stroma. So it's also normal side effect of the orthocare. You don't have to worry about that, but you need to know that. What we can suggest, it's not confirmed by articles or some paperwork, but we can suggest if in the center we have some, like we losing some nerve fibers, right? So probably the trophic and sensitivity of the cornea in the center may be altered by this, right? If we change by applying the lens, side effect is changing the morphology and density of nerve fibers. Probably, maybe, it might lead to decreased sensitivity or even some trophical disorders with patients who are predisposable for that, So you have just to keep in mind that information, and it will help you later with me to go through, the list of complications. So we can divide all complications in two main groups, like most common and those which not result in serious consequences for eye health. For instance, transient corneal staining, which is easy manageable, or induced astigmatism, which is easy manageable by just stopping wearing the lens. So you just stop wearing the lens and your front surface of the cornea will come back to the initial shape, actually in 2-3 weeks, 1 month. So we don't care about this kind of complications. They are pretty easy to manage, but we should know about, factors, risk factors for them, of course, and how to manage them. But we worry about rare complication, but with much greater risk for ocular health, and which may lead to permanent loss of vision, like severe infectious keratitis or even corneal ulcers. So, first of all, I want to go with you through the refractive complications. What we can see during the corneal reshaping. So corneal reshaping may result in undercorrection, overcorrection, induced astigmatism, halos, and regression during daytime, very quick regression during daytime. What refractive changes during ortho-K we can meet? So if we achieve a bull's eye pattern, which is gold standard for ideal fit in ortho-K, so when we achieve this bull's eye pattern, it means that our apical clearance under the lens is correct. In this case, and lens is well centered. In this case, we expect about 50–60% of the target refraction to be achieved after even one night of lens wear. Normally, we expect to correct the refractive error totally, completely during first 2 weeks of the treatment. So if you see under correction, for example, you started with a patient with a -5, and after 3 weeks of wearing lenses, you are still on -3 residual refraction, it means something went wrong. So no need to wait anymore, and you need to act to change the situation. You need to change the fit. What else we can see under response or under correction? Normally associated with flat or steep fit, which also can induce some astigmatism. I will show you examples later. And just a moment. Sorry for that. So when you talk about under correction or under response, what signs and symptoms of this condition? Of course, blurred distance vision during the daytime. You see under-corrected refractive error. And why it happens? Probably because you choose not correct back optic zone radius or BC. And the second reason, unresponsive cornea. Some patients have rigid corneas, which may not, respond to the treatment. So in this case, you normally just need to increase target reduction in your calculation of the lens, or change back optic zone radius. Small treatment zone will lead to the halos. Of course, if you did the small treatment zone and its diameter about 3 millimeters and daytime diameter of your patient's pupils is about 5 millimeters. Of course, at night or evening or in these conditions, those patients will suffer from halos. So when it happened, normally just when you have a high target refractive error, so you want to reduce high myopia, for example, -7. And as I mentioned before, the only way to do that is to use the lens, which will form a smaller treatment zone on the front surface of the cornea. So probably in this case, it would be logical to partly make a partial reduction of refractive error, and then correct the residual error with spectacles during the daytime, or some soft contact lenses, for instance. What other problems you may face? Lens is central, but what possible refractive problems you may have? So when lens is centered properly, you can find your patients, for example, overcorrected. Probably it's because of formation of true central island. And so when it happens, when the lens is too deep, and instead of flattening the central part of the cornea, we make it steeper because there is inadequate forces under the lens, which lead to formation of this central peak on the front surface. And of course, it will make shift to hyperopia, and you will see your patient overcorrected. So again, you need to check the feet, check the topo, and rule out this true central island. If lens is decentered, of course, it will cause less myopic reduction than you expected initially. It will induce astigmatism, and of course, it will lead to halos, glare, because take a look on these pictures. Your patients will get some part of this red ring, which is area of steepening, close to his central optical axis, yes, so to the center of the cornea, and it will cause this induced astigmatism, like in this case with lateral decentration. So in this case, we see that lenses is decentered to the to the one of the side, left or right of the eye. Normally, it happens when your lens diameter is much smaller than horizontal visible iris diameter of the patient, and remedy for this case is to recheck the diameter of the lens and to adjust the diameter of the lens, and normally it should cover about 90-95% of the corneal surface. So you need just to increase the diameter and probably decrease the lens sagittal depth to prevent, bending of the lens to the cornea. So lens centration is crucial, and any decentration will lead to the corneal staining. And corneal staining, which is actually colored areas of disrupted epithelium, will definitely lead to the complications like keratitis. So when we talk about corneal staining, we should know that it is very common among ortho-K patients. Every fifth patient has some level of corneal staining. About 20% of patients who wear ortho-K have corneal staining. When we talk about corneal staining, first of all, we need to know when it happened. Again, flat feet or steep feet will induce corneal staining because it will squeeze the tear film under the lens, or excessive lens movement will, just mechanically interact with the front surface of the cornea, leading to disruption of epithelium. So your lens should be centered again to prevent corneal staining. What other reasons for it? Maybe some reaction to deposits which accumulated behind the lens surface. So you need to check the lens condition and clean the lens regularly, right? Probably your patient didn't get good habits after training about application removal techniques, and he or she cannot properly remove the lens from the eye. So it will definitely lead to central or peripheral abrasion of the cornea, and also will give you central corneal staining. What other corneal staining patterns we may face during ortho-K? So it's diffuse corneal staining, superior or inferior conjunctival staining. When lens is decentered superiorly or inferiorly, of course, some part of the lens just sit on the conjunctiva and a part of the cornea. So we'll see staining here. Diffuse staining, normally when your lens is bigger than needed and when alignment zone goes behind the limbus. So again, tear film is squeezed underneath the lens, and it may cause this disruption of epithelium. What else we can see? Lens imprinting on the cornea. It's a negative staining. There is no real damage of the epithelium, but it's an imprinting after excessive pressure of the lens. When your lens is fitted too tight or steep for a given cornea, you, after removing the lens, you will find the lens imprinting on the cornea. What other things you can find? You see like a liner abrasion of the cornea and dirty lens. Of course, it will lead to, staining. What else you can find? Dimple veiling. So it's when ear bubbles trap behind the lens and they have this multiple indentation on the corneal surface. So it's not a big deal, actually. It doesn't cause the damage of epithelium, but it's a sign of a tight fit or steep fit. So you need to loosen your lens a little bit to prevent this, ear bubbles underneath the lens. Because if lens is filled with ear bubbles, it will never give you proper refractive treatment, right? So it will prevent the epithelium from changing to flatter epithelium in the center. So what also very useful in this case, if your patient faced with this, is application of artificial tears on the back surface of the lens before insertion. It really helps to reduce this dimple veiling. So you may see different types of staining. It happens because during nighttime, in conjunctival cavity, the temperature is increased. We have some acidosis. We have some deposits of like a hypercapnia. So it's deposits of metabolic products, and it also leads to toxic reaction of epithelium. And when you see corneal staining, first of all, you need to grade it, because it is very important what kind of, what level of staining do you see. If it is mild, some punctate staining around the cornea, we don't care about this. It's a kind of normal picture. But when we see corneal staining more than grade 2 or above, I use CCL-RU gradient scale or Efron gradient scale. So you need to retrieve them and use them. So if we have a corneal staining classified as grade 2, we need to think how to improve the fit again. Go with patients through the lens care protocols and procedures and find the reasons of this, let's say, corneal staining, right? So we need to prevent it from happening, because corneal staining means that disruption of epithelium will attract infectious agents to your cornea. So when we talk about infectious keratitis, which is very serious complications, we need to remember that we have our natural, protective system, how our eyes protects themselves from infection. We blink, but we don't blink at night, right? We have tears which wash out the infection all the time, and we actually we don't blink at night again, and we don't have this tear exchange under the lens like in daytime condition. And we have epithelial barrier between, like desmosomes between epithelial cells, to prevent the invasion of infectious agents. So for development of keratitis, you have to have two main factors, like damage of epithelial barrier. No matter is it mechanical, toxic, or other reasons lead to that damage, like abrasion or just a severe corneal staining from toxical toxic reaction from multipurpose solution. It doesn't matter. If you have the damage of the epithelial barrier and you have infectious agents all around, there is no deficiency in infection around the eye, right? So earlier or later, it will be resulted in actually in keratitis. So that's why we need to, early detect the corneal staining, prevent it's happening during the orthocare, and remember about hygiene, of course, because those two factors are very crucial for prevention of keratitis. Bad news that among all microbes which can cause keratitis among orthocare wearers, we have two leaders which are Cantamelba and Pseudomonas, and they are very aggressive infections which are very difficult to treat, and both of them may lead to the permanent vision loss. So if we talking about Acanthamelba, first of all, you need to know that it is everywhere. So we can find it in every environment, including soil and especially water. All type of waters, bottled water, domestic tap water, in swimming pools, everywhere. So even boiled water can have some, some amount of Acanthamelba. It's very difficult to eradicate it from the water. So it was a epidemic in 1980s in United States after the FDA approved the making of saline solution to provide the contact lens hygiene. So patients made saline solution from salt tablets, and it resulted in a huge, let's say, epidemic of Acanthamelba keratitis. And for now, it's absolutely prohibited to use any type of water in lens care. We are very thankful to British Contact Lens Association. They even, make these labels for contact lens. When you sell any type of contact lens, you put this label for patients to remind them that, tap water or any type of water is prohibited from using for lens care. What you have to know about Acanthamelba is that it's a free-living amoeba, and it may, go to one condition to another, depending on some conditions. And it's when it comes to trophozoite forms, it's nearly impossible to eradicate it from the cornea. So when we have a damaged epithelial barrier and Acanthamelba is in, for example, patient just rinse his or her lenses with the water after cleaning with cleaning cream or cleaning system for RGP lenses, and then rinse it out with water. Some Acanthamelba can still sit on the lens and then come into this, through this epithelial damage, into the cornea and actually deeply into the stroma. So it's nearly impossible to, to eradicate it from there. You need months of treatment to take off and to treat the acanthamelbic keratitis. So remember that good hygiene is a must in overnight reshaping, and it's our responsibility to make sure that patients understand the contact lens handling. And if you see that patient is not, his personal hygiene is not good, it's better to say no in the beginning. If you think that I just got it from the internet, this one, this one was mom with her son. She brought it to our clinic. So every time patients come in, We ask them to show us the case, the lenses, and this tool we use to put the lens on. So, and she actually just show us. So can you imagine, people really think that it's normal condition of this tool to use it for, you know, placing the lens on the eye. So we were really, you know, shocked by this, but people really use this stuff. So it's your responsibility to check it on every visit. What is the condition of all supplements, you know? Again, about 90% of all acanthamoeba keratitis is contact lens associated. And acanthamoeba takes 1/2 of all keratitis which happens during orthokay. So we have to be very careful about it. When you can, you know, guess or suspect the acanthamoeba. So about clinical presentations. On the early stages, you can see the picture like this. It's like pseudodendritic changes in the cornea, which may lead you to herpes zoster or herpes simplex infection. And you see this dendritic-like lesions on the cornea may, you know, they first of all, they give a very strong painful syndrome. So pain is much stronger than the clinical changes, than the changes on the cornea. Herpes simplex, by the way, normally decrease the sensitivity of the cornea. It's not as painful as acanthamoeba. So first of all, you will see this type of keratoneuritis, let's say, and then again, so this disappropriate pain to the clinical findings, you know. So cornea looks pretty good, not as bad as the complaints of the patient. And after about a few days, you can see, few days and week or two, you can see the development of this typical ring infiltrate in stroma. It means that acanthamoeba is there, and of course, like grade 4 conjunctival redness and pericorneal injection, and all the stuff like pain, redness, photophobia, decreased visual acuity, tearing, all typical for keratitis. So there is no, again, you cannot treat this kind of patients in your practice. You can refer them immediately to the emergency department, ophthalmological emergency department nearest to you. To do that, you need to know who provides the emergency care in your region around you. And before your patient leaves your clinic on the first initial fit, you have to provide him or her with information, what to do in case of emergency. So you should know who can help him if he, you know, experiences severe pain, redness, tearing, photophobia, all this stuff. So what can you do when your patients go into the emergency department? So this is the most common anti-amoebic medications. Actually, there are 3 groups of them. So topical biguanides, it's a chlorhexidine in concentration 0.02%. And you can use it if you have it in your country. You can dilute it and have it just in case, you know, in your examination room or in your clinic, just in case you need to add it to the patients. You can definitely prescribe, if you can, some antibiotics drops and add chlorhexidine and refer immediately to the emergency department. Same story with Pseudomonas aeruginosa. It's gram-negative rod-shaped bacterium, which cause another 50% of all keratitis during orthocare. This one is even more stronger because, it's normally triggered by contact lens wear and corneal trauma. And the bad, stuff about the Pseudomonas, it can progress very rapidly and lead to corneal scarring or even melting within 24 hours. So you see the hippopion here. So it's like a keratouveitis, which developed very, very rapidly. And even endophthalmitis can be developed in 1 or 2 days after first signs of Pseudomonas keratitis. And now we talk here about even saving the eye, not saving the cornea. So it's the main task is to save the eye for this kind of, infections. So it should be treated, and immediately you need to refer your patients to emergency department right away when you see the signs of Pseudomonas. What are signs actually? So again, pain, redness of conjunctiva, photophobia, tearing, and this ring infiltrates, which looks very similar to acanthamoeba. So as you know now, they are both very dangerous. So what you can give if you have this opportunity, like antibiotic drops, ciprofloxacin, 1 drop every hour, while your patient on his way to emergency department. Some other complications which you can face during orthocare, it's a lens bending. When the lens is too tight or bigger, as you can see on this slide, the lens is definitely bigger than the horizontal diameter. So it actually sits on behind the limbus, on the sclera. So, and actually you see the zero mobility of the lens, zero, movement. And you need, if you ever worked with scleral lenses, we use this method of, squeezing the sclera a little bit, or we push and pressing the sclera to, get some air underneath the lens. So same method is used to, to start to lead to, to let the lens move in a little bit. And in future, you just definitely need to change the fit to make it flatter, to control the diameter of the lens, and to use artificial, preservative-free artificial tears to prevent this kind of complication. So, in general, how to avoid complication in overnight corneal reshaping? So you need to carefully select patients. You need to rule out contraindications. So you need to rule out any diseases of the cornea, including severe dry eye, which will lead to corneal staining, and again, which will be a good platform for developing of keratitis. You need to rule out any corneal scars, any poor eyelid architecture, systemic disease that may affect the eye or can be, can start, lead to some keratouveitis during the lens wear. For example, kids with diabetes or systemic autoimmune disorders are not good candidates for orthocare at all. And of course, you need to rule out irregular corneas like keratoconus or other types of corneal ectasis. So why scars are a bad idea for orthocare? You can see on this slide, scar is actually covered by epithelium, but epithelium here cannot be attached tightly or properly because there is a defect in Bowman membrane. And when you apply and remove orthocare lens, you can easily make a, like a corneal abrasion in this place. And again, you open the gate for infection and it will lead to serious complications. So pre-treatment examination should always include corneal topography to rule out any irregularities, objective and subjective refraction, of course, to take those patients which are within the method, limits of the method. Biometry, to know the initial axial lens, and proper slit lamp examination with a fluorescent probe to, to rule out some damages on the corneal surface and to rule out dry eye patients. And we also do tear stability tests to know about tear film before we start the orthocate treatment. And then you proceed with your feet, and you should be satisfied only when you get an ideal bull's eye pattern, like on this picture, and ideal topographical response. And when your corneal health during follow-up visit is not compromised. Before your patient leave your clinic, you should teach him or her in clinic and provide some online sources to repeat the learning session at home to know about how to handle lenses, how to take care about them. So you have to give proper handling instruction. What I do for my lens care, let's say, what I recommend, it's my subjective opinion. So for everyday care, I recommend my patients to rinse and store lenses in either RGP multi-purpose solutions, or for RGP lenses, or off-label, but still very efficient. I recommend them to use solutions for soft contact lenses. One of my favorite, I don't have any financial interest, of course, in this mentioned products, but one of my favorite is PSPHOO, which actually has some better protection from acanthamoeba, by the way. So that's why I choose it, and it doesn't lead to corneal staining in my patients. So that's why I like it. They also can use on everyday basis, or at least once a week, peroxide systems, right? I love this one from DSOP companies from Spain, I believe, because it makes a full cycle within 1 hour only. So you don't need to wait forever to disinfect your lenses, So once a week, I recommend a deep cleaning with a project by Manicon, if it is available in your region, or ultrasound cleaning systems for soft contact lenses. They're very good in, removing the debris from the lens surface. They never use tap or other water because, again, every case of acanthamoeba is associated with using of tap water for lens care. So they never rinse the lens with a tap or other water. So if they use creamy, non-abrasive cleaners for RGP lenses, like Delta, for example, then they rinse their lenses with the saline solutions, non-preservative-free salines, but it's very rare among my patients. And before applying and removing, they use preservative-free artificial tears, to make the surface a little bit wet and smooth. And if your patient use anesthetic drops, some practitioners recommend anesthetic drops during first 1 or 2 weeks of using orthocare lenses. So in this case, you have to make sure that they don't use them longer than you prescribe to them, because some patients want to use it forever. Of course, it's very comfortable to put some anesthetic drops and put the lens on and actually go to sleep. They don't feel any foreign body sensation. However, it will definitely lead to change of corneal sensitivity, and it will definitely lead to the corneal staining, which is again risk factor for development of keratitis. So if you use anesthetic drops, make sure that they don't use it too long. And we check the lens's condition under the slit lamp on every visit. Every patient knows that if you come to the visit and you forgot your lenses or your case at home, you can go home, because we want to make sure that everything is in good condition, that the lenses are clean, the case is clean. We recommend to replace the lens case every month at least. They can do it more often if they want, but at least every month they need to, to use a new, fresh lens case. And during every visit, we check the lens condition, like on this slide. You see, so before cleaning in ultrasound system, we have some debris and on the lens surface, some deposits. And after the cleaning the lens, you see it changing, its condition. So it looks clean, yes, with some minor scratches, but they are not dangerous for, cornea surface at all. So what we recommend is a follow-up schedule. It's to see patient on after the first night of the treatment in the morning, then 1 week, 2 weeks later, and in 1 month, and actually 2 weeks visit or 1 month visit. We want to see the patient at the, at the end of the day, like evening time, because we want to make sure that there is no regression of orthoke effect during the day. So normal regression is about 0.75 diopters during the day. So if you wake up with a refraction about, 0, for example, so at the end of the day, it is normal to have minus 0.75, minus 1 at the end of the day. It will not affect your vision function actually dramatically. So, and evenings, most of the kids, they spend at home. They don't use like, infinity tasks. They don't have any infinity task at 10 p.m., right? So you need to check this as well. And on each visit, we do slit lamp examination with a fluorescein probe. It's an obligation, and corneal topography to make sure that there is no decentration. As you remember, that decentration will lead, again, besides refractive changes or refractive dissatisfaction of patients, any lens decentration will lead to corneal staining. Earlier or later, it will definitely damage the epithelium, because there is no normal correspondence between the inner surface of the lens and anterior surface of the cornea. So it will lead to the corneal staining. Corneal staining will lead to the infectious keratitis. Of course, again, hygiene is crucial. Check the condition of all tools and all stuff your patient uses. And the most important part, your patient has to have access to the doctor 24/7. So all my patients, absolutely all my, it's more than 5,000 patients, and it means about 9,000 eyes, right? So every mother has my private phone number, clinic number, and the phone number of my fellow doctor. So as I like to mention, before I can call to my mother, so I go through, when you search your mother in your phone, you put mother. So I have a whole list of my patients' mothers, because they want to have my number 24/7. So we connect with them through Viber, WhatsApp, Facebook, whatever. You can use email for emergency purpose, but you have to make sure that somebody check it, because if your patient got the Pseudomonas keratitis and you will not help him or her within hours, first hours from the manifestation, your patient can actually lose vision forever. So it's absolutely crucial, essential to provide really 24/7 access to the doctor. Some cases in Russia, because they are now our neighbors, also showed us that in two patients cannot find a doctor within 3 days. So they were sitting at home for 3 days using some, like methods of treatments from the internet, and both resulted in penetrating keratoplasty later because they cannot, find their doctor, and they were not really, how to say, absolutely confident or aware that they have to go to emergency department. They thought that something like a transient infection, which will go on after they will put some holy water in the eyes, so just artificial tears. So this is very important part. Please provide, if you want to do ortho-K and you don't want to see any complications, you should go through this whole list and provide access to the doctor. And about lens replacement, it should be done every year. Some companies, for example, like Manicon, I just, stole their label. They put this information to the label of their ortho-K lenses, some not. But normal schedule for replacement the lens, ortho-K lenses, is annually. So every year you should call to your patients and invite them to your clinic to replace the lenses, because normally they feel that everything is okay, I'm good, why should I, pay you money again? I can wear my lenses for 2 years, for example. You definitely seen patients who wear, daily disposable lenses for months. I seen them. So same story with ortho-K lenses. So on your initial visit, before you feed them with ortho-K, you should, remind them that they spend money for ortho-K, not for, it's a not lifelong, lenses. They need to replace them every year, and they need to follow up, to visit all follow-ups, don't miss follow-ups visits, sorry. And actually for some patients, if I see that they actually after the first night they disappear, we call them, and if they don't come back to us after 3 reminders, we discharge them from our clinic, because for me it means that patient is not responsible, or parents are not responsible enough to continue with this type of treatment. So careful selection of patients, ruling out contraindications, follow-up visit with, very thorough check of lens condition, cornea condition. Actually, it's all key for your success with ortho-K. So I'm done for today. So thank you for your attention. You can join us in the International Academy of Orthokeratology if you want to, get access to publications, conferences, material, to join our, international team. I'm very happy to invite you there. So thank you for your attention. Thank you very much.
Wow, that's wonderful. Thank you, Doc, for that really comprehensive. I think you covered A to Z of orthokeratology. It's important, as you said, that you start with patient selection. To understand complication, we must know the basics, right? And a couple of very good take-home messages, I would say, from the presentation. And thank you so very much, for doing this talk for us.
Thank you.
We do do have some questions. We received one or two during the presentation, and also a couple of them were also received during the registration. So I'm just going to ask them straight away. You talked about the corneal ring formation, and you said that it's quite normal and it will go off after some days of wear, right? Any particular
Yeah.
reason which you can tell us why this happens, or what is that?
Okay. So short answer, the reason is unknown yet.
Okay.
But all these iron deposits, actually we have iron inside our epithelial cells. I
Yeah.
didn't know that either, but recently I found some information that iron and combination of iron salts, let's say, within the epithelial cells is actually essential for protecting the inner parts of the eye from ultraviolet. I didn't know that, so I found some literature about that. So we have iron in our epithelial cells of corneal epithelial cells, but when we change their shape and when some part organelles, of the cell move inside, it probably lead to this formation of iron deposits. So it has no clinical significance at all, like irrelevant. But it's probably because we make the cell a more thicker and like we pull it a little bit in the vertical direction. So we pull it and we change its form. It doesn't happen in the central part of the cornea, not at all. It just in the mid-peripheral cornea where we pull the cells. And actually, sometimes when I look into the slit lamp, I can judge the centration without topo, because if this iron ring is well centered, so it means it corresponds to that red ring of steepening in the topography. So I can have some clue that this lens is well centered, let's say. But again, official answer, the reason is unknown.
All right, yeah. Because it looks quite similar to the Fleischer's ring we also observe in corners,
Yeah.
right?
Yeah,
So,
yeah. Looks very similar, but again, central cornea has some thinning, right, in the keratoconus.
Yeah,
It
yeah.
means if central cornea is thin and change its shape, so comparing to the central part, the mid-peripheral keratoconic cornea is also thick, right? So probably there is there is no explanation of that ring as well,
That's
right? So
Yeah.
it's unknown yet. Sorry.
Yeah. Good, I think, postulation, as you mentioned, that epithelium has some iron, and because we are reshaping the epithelium, and it's probably happening at the mid-peripheral area where, the epithelium is thickening. So maybe that could be something which can be researched on as well. The other
We have.
question, uh, do you advise or can we practice orthokeratology without a topographer? Any thoughts?
I believe it's impossible. I believe it is impossible because within first months you will get complications, definitely. You cannot control the lens position only by fluorescent pattern. Sometimes when you patient with open eyes condition under the slit lamp, when when you put your fingers on the top of the eyelids, or when you see the blinking, so it looks for you absolutely centered. But then during the night, under again when other factors work on the like a lead pressure, like a gravity, like a horizontal position of the patient, it may change the position of the lens completely. And you will see induced astigmatism, for example, on your refractive readings, but you will not get any idea. Is it because of flat feet? Is it because of steep feet? Is it because of lateral decentration? So I believe, sorry for that, you need to have any type of topography to proceed with ortho-K. It's a criminal, I believe,
Yeah,
you know, with a joke, of course, to proceed without. You need to buy it as soon as you want to, you know, fit ortho-K lenses.
that's right.
I
Yeah,
see very nice and very interesting question here.
yeah.
How do we assess the corneal epithelial thickness to ensure it doesn't go below 20 microns? And in which follow-up visit do we assess the thickness and the change? Okay, so first of all, smart people decided everything for us, first of all. What I mean that most of manufacturers don't offer you to correct the myopia greater than -6, for example. It also means that they already incorporated, you know, they designed the lens to prevent this, you know, decreasing of central epithelial thickness below 20 microns. So first of all, but if you want to check it in clinic, you can do it. But for doing this, you need to have either OCT or Pentacam, you know, some kind of pretty expensive equipment to check the pachymetry on every point, right? So you can see this on a pachymetry map. For example, we work with Optoview, okay, they provide you with epithelial thickness map and stromal thickness map and total thickness. So you actually need to have this kind of pretty expensive stuff in your clinic, and then you can measure whatever you want. So when up to 1 month, some changes still occurs. So 2 weeks, first 2 weeks of treatment, the like 90% of flattening happens in the central part of the cornea. So it means that up to 1 month, you actually done with your treatment, let's say. Then you just, then you wear lenses just to maintain it.
Okay, yeah, that's right. Great. And one other question, which is kind of related to it, in which follow-up would you decide that this lens is working for the patient? Is there any, like, you want it to work within the first follow-up or the second
Mhm.
follow-up? How much duration do you think?
You actually make this decision on every follow-up visit. For example, during the initial visit of the patient, when we fit the patient with a new lens, right? So we let him or her go from our clinic only if we're satisfied with fit, right? So lens is centered, cornea is healthy, refraction over lens is appropriate, which means about 0 or small plus over the lens. Okay, so okay, we good, we can let them go. On their next visit, which in the morning, we check all these checklist parts again, and we should be satisfied with every part, plus topographic response. So if lens is centered during the fluorescent probe, if topo is centered, if healthy cornea, or we have a corneal staining less than grade 2, on a scale you use, and we see some, reduction of refractive error, we say, okay, you're good to go, and we repeat the same steps on every visit. Probably you may be not satisfied with a lens after 3 months of wearing, something like a late decentration, it happens, very rare, but it happens. So normally you have to make all changes you want as practitioner within first months of lens wear. If you do your job properly during the first month, the chances are very low that you need to repeat that again. So what I want to say, on every visit, we check, is this pair of lenses still good for this patient, something like this. So there is no borderline, you know. If I see that late decentration happened in 3 months after initial visit, I still need to replace them, yes, and to make this fit ideal. So there is no final step or final line. Each follow-up visit, we do the same stuff.
All right. Yeah. So can I say that the first 1 month is very crucial so that you decide a lot of things within the first 1 month whether it works or not, and then the subsequent visits will help to maintain whether everything is going on good or not.
Mhm.
Is that
Yeah,
right?
absolutely. This is correct. First month is crucial, and you have many follow-up visits. You have many opportunities to improve your fit. Yes, to make it absolutely perfect. So yes, absolutely true. After first month, you just maintain the effect. You control the hygiene, and
Mhm.
you control the lens conditions, and you control the topo response, and you see patients not every day after first month. You see patient every 3 months actually during first year.
Yeah. 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 That's great. And one connecting question to this, it just popped out in my chat, is just like when it comes to advising your patients, do you tell them about the complications, and do you tell them about all of this before you deliver the lens? Do you make them aware, or any tips you would share with us on how do you do patient communication? How do you tell your patients that be aware of all of this, and we do need to be sure of this does not happen or something like that?
So what I didn't mention, sorry for that, that before every new patient who was fitted with the Ortho-K lenses leaves the clinic, they sign the informed consent. So in Ukraine and in Eastern Europe, I believe, there is no governmental clinic who provide Ortho-K treatment. So we are all in private sector, right? So we are all in private practices.
Yeah.
And of course, I'm telling the patients that, like before any surgery, any ocular surgery, any other health condition. So doctor should provide you with information about, first of all, rate of complications, when and why it happened, because we both have responsibility. You as a doctor have responsibility to make the fit proper, right? To make it well-centered, to choose proper lens for this particular patient. But patient responsible for all lens, handling and hygiene, for washing his hands. You are not responsible for washing his hands, right? So we discuss. For me, I fit lenses in 10 minutes, let's say, for now.
Yeah.
And I discuss all other stuff during 30 minutes, So, and after this discussion of complication, possible reasons about our responsibilities, both patient and doctors, they sign the informed consent. It's very important part of your cooperation, because when something happened, people keep forgetting that you told them that they need to wash their hands before applying lenses, or they need to change the solution not every month, but every day, yes, for storing the lenses. So when something happens, then they immediately, most of people lose their memory right now, yeah? So to prevent that, you need to make everything documented. So we give them the information list about other alternative, methods, like a soft contact lenses, like glasses, like atropine if they're interested in myopia control techniques. And we tell them about the method briefly. So we always tell them about potential complications. And actually, I believe this is very suspicious if your doctor don't tell you about the potential risk. If you come to the doctor, if you as a patient come to the doctor and he or she said to you, never mind, everything will be very, very good, everything will be fine. personally me, I'm very suspicious to this kind of specialist, because we all know that it is pretty impossible, yes? So we prefer to honestly tell them everything about potential risk, and we make a very, focus on prevention from proper handling and care.
Yeah, that's right. And I think when you started your presentation also, you said that we are looking for minimizing all of this. You are definitely going to get it, but what we want to do is we want to minimize, and we want to make sure that it doesn't affect patients' vision. We catch these things early, and we start managing at a very early stage to prevent, more.
So
So
prevention, as everything, prevention is a key, like in every part of medicine.
that's right. And I like your point that, you said that you probably take very little time in fitting, but majority of the time is on patient consultation. And I think that's really important for all of us to understand that we have to spend a lot of time talking to the patients, explaining them, and also making sure that they understand what we are telling them, right? So that they
Exactly.
focus, and it is a repetitive process. We do it on all follow-ups as well. So I think that's a very good take-home point. Couple of more questions here before we can, wind up for today. There was a topo map which I think was showing a purple ring pattern. Anything you would like to comment? What advice you want to give us? What adjustment should we make when it comes to that purple ring? I'm not sure which topo map, but
Can I
showed
see
a
the question, please?
yeah.
So I see one about washout period before refractive surgery,
Yeah,
and
that's one, but yeah, I mean, you can answer that, and then we'll take one is on the screen, which I've just posted up.
just a moment. Just a moment. Let me adjust my screen. What is the next adjustment we need to do when so purple ring in topography map? Uh, Purple versus red, right?
Yeah,
Probably. So first of all, I would check the scale, an absolute or relative scales of color which your topographer uses. So you need to go through the settings of topographer and actually change it, if I understood the question properly. So there is no purple ring in under the normal circumstances.
that's
The
right.
topographer may show you the ring as purple when you probably use an absolute scale, probably. But it's good when you see it. It's good when you see the ring, especially if it's centered according to the pupil size, and pupil center. So if I misunderstood the questions, please ask it again. I will
Yeah,
go through another one.
sure. So,
Important.
yeah,
What is the washout period if patients planning to undergo refractive surgery? Very good question. So normally when you start with 8-9 years old kids, so my average age of starting average, I would say 9 years old. You know why? Because kids go to school about 7 years old here in Ukraine. Nobody checks them properly, their vision before 7, before they go to school. Parents finally found that their kid have some problems, initial, like low myopia. Then nobody pays attention to this up to 10 years old, when acuity, visual acuity decreases to the, like 20-30% for distance, and they finally start to go to the doctor. So my average age of starting ortho is 9 years old. So normally my kids grow up with us, with our practice, until they are 16 or 17 or even 18. So when they are stable and we can refer them to refractive surgery. So they stay with us for years. Why I mention this? Because first of all, there is no limit of years
In orthopedic, yeah.
During there is no limit of how long you can use lenses. If you replace them manually and if you control the eye health of your patients regularly, so you can use them for 10, 12 years, I mean, you know, with the annual replacement, of course.
Yeah.
So after they finish their Orthokay program, because we actually like it's like a model of future refractive surgery, but temporarily, right? So during the Orthokay, they use the lens at night, and they have a freedom during the daytime. They spend their life without glasses or contacts. So of course, when they reach 18 years old, of course, the only thing they want to do is a laser vision correction. No
Right.
way you put the glasses again or soft contact lenses to this kind of patients. The only reason they are not good candidate for refractive surgery. You know, in all other cases, they want to proceed with refractive surgery. So we need to decide either this patient is a good candidate or not. So answering the question, washout period is it is depend on many reasons. So at least you need 1 month, at least 1 month to stop orthokay, to, you know, to get your cornea to initial baseline. If you are lucky enough and you have an initial topo of your patients before fitting, right? So enough, how to say, just let me paraphrase it. So to make sure that its wash out period is done, you just need to compare electronically your topo before treatment and topo after discontinuation of orthokay, right? If
Yeah.
they are absolutely equal, you can say that you did the proper washout period. However, some patients, and you need to keep this in mind, it's a very good question. Some patients need up to 3 months and even up to 6 months to come back to initial, you know, shape. It's very rare, but it happens. And some corneas are really rigid, you know, to the any treatment. So sometimes you need to wait longer. So every time you, for example, you told to your patient, stop wearing orthokay lenses for 1 month and come back to me. And if you can compare, you know, initial pre-treatment topo with your current topo after 1 month of discontinuation, then you're good. If you see any residual signs of orthokay treatment on your front surface, you need to continue, you know, just
Monitoring.
living without lenses and come back in 1 month again.
That's right. Yeah. So I think that's really important because, as you said, these kids will grow up and then, they want to undergo laser refractive procedures. And I think
Definitely.
they ask us because we have been taking care of them for so many years. As you said, you start at 9 years of age and then, they can only go for refractive surgeries at 18. So probably you have seen them
Exactly.
years of life. And
Yeah.
they will be trusting you. So they'll ask you, okay, can I or can I not? And when should I? And how should I? So I think it's really good for us to understand and explain to them that, as you said, 1 month is something which we are looking at, but it can depend on individual to individual and it can be longer in some people as well, right? Yeah.
What we also mentioned during initial visit to our patient, we use sometimes, you know, this myopia calculator from Brian Holden Vision Institute, you know, when you can online predict a little bit
Yes.
let's say the final refractive error when your kid will be 18 years old. Okay, so now he or she is 9 years old, and with what refraction we will end up when he is 18.
Yeah. Yeah.
So when we do that, we also show to parents that if they choose the orthokay option, yes, among all other possible modalities, that we can, you know, end up with a much lower numbers. And besides all other benefits for eye health, it may be very crucial for this particular patient in his future to proceed with a laser vision correction, because you cannot correct like minus 12, okay? Okay, you can, but it's not so good idea. Anyway, it depends of your corneal thickness, right? And refractive error. So as soon as we can keep the refractive error controlled and on the lowest level possible, besides the potential health benefits, again, I will repeat that, we can offer to this kid future, desirable profession, for example, or future another level of life quality. So I believe you can discuss it with every parent, in your clinic.
That's right. Yeah, great. And one last question we just came to me here is, do you think there is role of corneal thickness for orthokeratology? Meaning that, do you look at corneal thickness rather than the corneal shape, or do you think that this is the corneal thickness I want and I will only do ortho if the corneal thickness is above certain? Do you think that is important?
Okay, so actually there is, if the cornea is healthy and regular, I don't care about thickness, because there is no, let's say, big difference on fitting the ortho lenses on thick or thin corneas. However, every thin cornea is a suspect for potential, keratoconus or other, corneal ectasis. So we prefer to analyze well, and even if I not always have, I work in a clinic which has other departments, and we have refractive surgery department. So I always can refer my patients, and I prefer to do that for initial topos, to do it on pentacam, so I can, rule out not only irregularities on the surface, front surface, like with every topo, but I can also check the pachymetry, right? And okay, so if I see the patient with a pachymetry of about 420 microns, it looks very suspicious for me why it happens. And probably we need to find first the reason of this low thickness, and the problem will be not a myopia at all. Maybe myopia is secondary to any other condition in this case, So we definitely will not proceed with ortho. However, if you check everything and you see that your cornea is healthy, because we can meet normal, thin, healthy corneas, right? Regular, healthy, thin corneas, then you can proceed with your ortho fitting, no problem, no special recommendations in this case.
All right, great. I think thank you so much, Dr. Nataliya, for that wonderful talk, and giving us your insights, and answering questions, and sharing your thought with us. Thank you so very much, and very grateful to listen to you today.
Thank you for your patience, and actually for joining me on Sunday night. Go drink beer. Bye.
Yeah, bye. Thank you so much.
Bye-bye. Thank you so much. It was a pleasure for me.
Most welcome.
Thank you. Hope to see you again somehow.
Surely, we'll do that.
Bye.
So thank you everyone for joining us today, and take care, be safe, and I'll hope to see you next week for the session as well. Thank you so much, Dr. Nataliya, for
Thank you so much. It was a pleasure to meet with you. Thank you for your attention. Bye. Bye-bye.
Bye-bye.